There's a lot to learn here. Okay, this is the outline. For the hemolytic anemia, you will learn about erythrocytosis, G6PD deficiency, and hemoglobinopathy. And also the immune hemolysis, red cell fragmentation syndrome, and other causes. Ada banyak ni. Okay, normal red cell lifespan is 120 days. But sometimes the survival may be shortened due to defect in the red cells. Most are inherited or due to defect in the extracellular factors, which is usually acquired. Okay. So anemia due to shortened red cell survival is called hemolytic anemia. It lies before 120 days. Normally 120 days baru lies kan? Where do you have the hemolysis? Spleen, mainly in the spleen, reticuloendothelial system. So it can be classified based on the site of hemolysis. Sama ada dalam vessel, intravascular or extravascular in the spleen. Okay. And it can be caused by hereditary. It can also be classified based on the cause of hemolysis, either hereditary or acquired. So dua cara classification. So let's look at the classification based on the causes, hereditary and acquired. So the hereditary causes can be due to membrane disorder. The red cell membrane can be in the form of hereditary spherocytosis and hereditary elliptocytosis. So we will only discuss HS because this is usually not clinically significant, elliptocytosis. And then it can be due to metabolic defect. This is PD deficiency, pyruvate kinase deficiency. Dah belajar dulu kan? Okay. Okay, kita akan go through more in the pathological part. And the hemoglobin disorder, the thalassemia, the sickle cell anemia, hemoglobin C, and other unstable hemoglobin. Acquired causes can be due to immune reaction. It can be autoimmune or alloimmune. Pernah dengar auto and alloimmune? Tak pernah. Auto is your body produce the antibody towards your own cells. Allo is antibody towards other cells. For example, you dapat blood transfusion, your body produce antibody towards that cell. Okay. Then you can have red cell fragmentation syndrome. For example, patient with prostatic valve, DIC, TTP, and HUS. And other small causes much hemoglobinuria, infections, chemical or physical causes, and PNH, paroxysmal nocturnal hemoglobinuria. So if you classify based on the sites, it can be intravascular or extravascular. So examples of intravascular hemolysis, red cell fragmentation syndrome, blood transfusion complication, the alloimmune tadi, chemical or physical causes like drugs, severe burns, infection, for example malaria, and PNH. The extravascular causes can be due to membrane disorders, metabolism disorders like G6PD, infection like malaria, drugs, immune hemolytic anemia, hemoglobin disorders, and environmental disorders, for example malignancy, TTP, and HUS. The RBC breakdown, ni semua dah belajar kan? This is a normal one, extravascular, so it will be degraded by the macrophages. It goes to the bilirubin go to the liver and it will be processed into urobilinogen and released in the urine, and also stercobilinogen in the feces. So biasanya you tak akan ada jaundice because it will be removed in the urine and the stool. Intravascular is not normal. So this is pathological. So the red cell will lies in the blood vessels and it will release the hemoglobin. This hemoglobin will go to the kidney and you will see it as hemoglobinuria and hemosideruria. You nampak hemoglobin dalam urine, red colored, and if it is chronic, you will see hemosiderin, the pigment. Dah belajar kan pigmentation tu? Hemosiderin. So this is hemosideruria. You nampak hemosiderin in the in the cells, epithelial cells in the urology tract. Yeah? Okay. So the mechanism of hemolytic anemia. For the intravascular hemolysis, the red cells is broken down in the circulation, in the vessels, and caused by mechanical trauma or damage by biochemical or physical agents. So this free hemoglobin will saturate serum haptoglobin. Pernah dengar haptoglobin? Tak pernah? Biochem belum tak belajar? Tak ada. Okay, haptoglobin is a protein in the blood, in the plasma. Okay, so kalau you ada free hemoglobin dalam plasma, haptoglobin akan bind dengan dia, because free hemoglobin is toxic. Okay, so dia akan bind dengan haptoglobin. Tapi kalau haptoglobin tu dah penuh, dah saturated, dia akan jadi free hemoglobin lah. Okay, so the excess free hemoglobin is filtered by the glomerulus. If the rate of hemolysis is more than renal tubular reabsorptive capacity, you akan nampak free hemoglobin in the urine as hemoglobinuria and hemosiderin in the renal tubular cells. For extravascular hemolysis, the excessive removal of red cells from circulation by macrophage in the reticuloendothelial system. Extravascular hemolysis is more common than intravascular. Okay. So when you have injured RBC, it will be immunologically altered or it has reduced deformability. Dia tak boleh nak berlentuk-lentuk liuk untuk lalu in the skin the capillaries. And it will be destroyed in the spleen, the reticuloendothelial system. And there will be increase in serum bilirubin, and you will see the bilirubin in the urine. Bilirubin, not hemoglobin. Okay, so there is no hemoglobinuria in the extravascular hemolysis. Okay, so you boleh bezakan lah from the clinical features tu whether it is intra or extravascular hemolysis. Yeah. So if you look at these features, you boleh bezakan intra dan extravascular. Both will have a lot, sebab sama-sama pun low hemoglobin. Jaundice pun boleh ada in both. Yeah. Splenomegaly only in extravascular. Why do you think you have splenomegaly in extravascular hemolysis?
Because hemoglobin breaks down in the spleen. Because the hemoglobin breaks down in the spleen. So the spleen, too much hemoglobin break down in the spleen, so the spleen becomes enlarged to compensate the hemolysis.
Because spleen is working hard, so it's like hypertrophy lah. So that's why you have splenomegaly, but not in intravascular hemolysis. The dark colored urine, you see it in the intravascular. Why is the color dark? Hemoglobin, and hemosiderin tu tak sangat lah, biasanya di dalam sel dia tak nampak sangat. The hemoglobin will give the dark coloured or red coloured urine. Pigment stone is seen in the extravascular, because in extravascular hemolysis, remember, you recapture the iron. Kan iron tu tak keluar, you tak lost the iron, you recapture. So you akan ada iron overload, and that will give the also the bilirubin pun overload. So you akan ada stone because of that excess. Bilirubin lah mainly, bilirubin stone. Leg ulcers seen in extravascular. Aplastic crisis can be seen in extravascular, especially the sickle cell anemia. Low serum haptoglobin is seen in intravascular. Why do you think you have low serum haptoglobin?
Because
dia dah bind dengan free hemoglobin tadi, but you don't see it in extravascular. So you can do serum haptoglobin to differentiate intra and extravascular. Okay. So the investigation, when you suspect a hemolytic anemia case, you should look at the full blood count, look for the hemoglobin level and reticulocyte count. What do you expect the reticulocyte count is? High or low? High kan? Your body will compensate. Blood film, look at the red cell morphology. Ada macam-macam cell you can see in hemolytic anemia. You may see histiocytes, spherocytes, white cells, blister cells, and reticulocytes. Kita tengok one by one lah. Urine examination, look for hemoglobin, uroglenogen and hemoglobin, serum bilirubin, serum hemoglobin, osmotic fragility test, pernah dengar? PCR tak belajar? Okey, tak apa, nanti kan kita tengok sikit. Coombs test? Coombs test pun tak, okey tak apa, nanti kita tengok. And other specific tests, enzymes, proteins dan DNA study lah. That one is based on case lah, dia bukan routine. Okay, now let's look at the specific case, hereditary spherocytosis. So as the name implies, the cell become spherocytes. Dia jadi bulat macam bola. Dia tak biconcave. Okay. It is due to defect in the protein involved in vertical interaction between the skeleton, membrane skeleton and the lipid bilayer. The most common affected protein is enchirene. So you ada defect dekat enchirene ni. And it will lead to bone marrow producing biconcave red cells, but they will lose part of the membrane when they pass through the spleen. Mula-mula dia biconcave, tapi blood ni kan dia pass through spleen tu. When the cell tu abnormal, dia akan makan part of the membrane tu. And after some time, cell tu akan jadi spherical. Okay. And the red cell will die prematurely in the spleen sebab dia dah tak boleh nak lipat-lipat masuk in the capillary. So it will be destroyed. Okay. So these spherocytes will have difficulty leaving the splenic cords. So mula-mula asalnya dia normal, tapi because dia ada defect tu, dia akan ada macam ni lah, defect in the membrane. So spleen akan remove this defect and eventually dia akan jadi spherocytes. Dia jadi spherocytes, dia akan lies in the spleen. So if you look at the cell, dia kecil daripada sel biasa kan, and it is sphere. So it is a micro spherocytes. Kecil dan sphere. So you can nampak in the blood film as micro spherocytes. So in hereditary spherocytosis, you can offer splenectomy because this will avoid the hemolysis. Okay, tapi itu last resort lah. Kalau severe sangat baru kita buat lah splenectomy. Okay, the clinical features, patient will have anemia or pallor. They will have splenomegaly because extravascular tadi kan. Fluctuating jaundice. Bila dia punya hemolysis tu banyak, dia akan ada jaundice. And reticulocytosis. And they can also have pigment gallstone. Remember the extravascular hemolysis tadi. And occasionally they may have aplastic crisis if they are infected by parvovirus infection. So the severity varies. It can be mild, it can be moderate. Tapi biasanya tak severe lah. And if you do the osmotic fragility test, there will be increased fragility which will have in the diagnosis. Okay, if you look the blood film, you akan nampak N-isocytosis. Faham ke N-isocytosis? N-iso ni tak sama. Cytosis ni size of the cells. So you nampak ada sel besar, ada sel kecil. Sebab dia jadi spherical and it in stages kan. So ada yang lebih kecil, ada yang kecil sikit. So that is an isocytosis. And you will see microspherocytes. This is lymphocyte yang size sel sepatutnya. And you will see the spherocytes tu kecil kan. So these are microspherocytes. And you will see reticulocytes. Ni yang purple-purple ni. These are reticulocytes. Okay. And when you do osmotic fragility test, the curve is shifted to the right, the north. Okay, kalau you tengok kat sini, this is the normal range. Tapi in HS, it will be shifted to the right. Any idea What is the basis of this test? Siapa biasa tengok normal saline yang selalu gantung dekat ward tu? Normal saline yang bagi patient tu? Biasa tengok? What is the concentration? Berapa persen? Apa?
0.9.
Siapa sebut tadi? Tak observer je. 0.9 kan normal saline solution. So that is the isotonic solution normal saline 0.9. So in this OFT kita bagi red cell tu in saline concentration start daripada 0.8 sehingga ke bawah lah. So in normal condition the red cell can stand up to 0.5% saline solution. Maksudnya sel tu bila you masukkan red cell in the hypotonic, air akan masuk kan? Ingat osmosis punya rule kan? Dia akan masuk ke dalam red cell. So kalau red cell tu biconcave, dia ada banyak ruang untuk dia kembang sebelum dia lyse. Okay? So the normal cell dia boleh stand up to about 0.5, baru 50% of the cell lyse. But in HS, sebab sel tu dah kecil dan dah sphere, dia tak boleh accept banyak saline solution tu kan. So at about here dia dah lyse. So maknanya dia akan shift ke kanan lah. So it indicates the cell is spherocytic. Okay, nampak dia punya basis?
Nampak.
Okay, simple je sebenarnya osmosis je. And then Coombs test, nanti saya akan cerita dalam immune hemolysis nanti. So in erythropoiesis it is negative, and then you look at the serum bilirubin, it is raised. Okay, clear HS? Okay. Banyak kes tapi biasanya tak adalah severe, not very significant lah. Not very significant. G6PD dah belajar kan? Okay. So it is due to mutation or deletion, and there are a variety of genetic variants. More than 400 types of mutation or deletion. It is X-linked, so it affects males, and commonly seen in West African, Mediterranean, Middle East, and also in our population. So it produces normal amount of G6PD in the precursors, but as it matures, it will decrease. And they are vulnerable to oxidant stress. Ibu, you dah belajar kan dulu? So kita boleh skip kan? Okay. They are usually asymptomatic unless they are exposed to the oxidant stress. So they can present in two syndrome. It can be acute hemolytic anemia in response to oxidant stress. Contohnya patient exposed to anti-malarial, antibiotics. And also infection can also cause hemolysis in G6PD. In a neonate, in babies, they may present with neonatal jaundice due to imbalance between the production and conjugation of the bilirubin. However, it is usually self-limiting. So the clinical features, they will have hemolysis of various severity, and typically you will see the hemolysis 2 to 3 days after the exposure. So history penting lah bila dia ambil drugs tu. And bone marrow will compensate by producing more red cells. So it is self-limiting. The hemolysis will stop. Sebab you ada the new red cells tu, dia punya G6PD high kan. So dia akan normalize balik keadaan tu. Okay. And the diagnosis is by looking at the full blood picture. Urine hemoglobin is usually positive, and G6PD enzyme assay. Biasanya patient ni dia ada kat G6PD deficiency tu kan. So you can diagnose very easily lah sebenarnya. And in G6PD deficiency, there will be denatured hemoglobin which will precipitate. So dia akan precipitate dan membentuk Heinz bodies. Nanti akan tunjuk what is Heinz bodies. And these Heinz bodies will cause damage to the RBC membrane. So it will cause intravascular hemolysis. Okay. And the red cells are less deformable and also will be further damaged in the spleen. So in G6PD, you ada both intravascular and extravascular hemolysis. It is a mixture. Ada dua mechanism. So this is the blood film of patient with G6PD deficiency. Okay. Okay, this is the Heinz bodies. Heinz bodies ni kalau dekat blood film biasa you tak boleh nampak lah. Kita kena gunakan special stain, supravital stain. You akan nampak these bluish dots. These are the denatured hemoglobin that we call Heinz bodies. Okay. And other cells that you can find in the full blood picture. Nampak tak sel ni? Sel yang nombor 2 ni, you call this a bite cells. Nampak macam kena gigit kan? Ni. These are bite cells, typical of G6PD deficiency. And there are also cells like this. Beza tak 2 dengan 3 ni? This is blister cell. Kalau you boleh appreciate, dia punya margin sini tak clear tau. And actually dia ada membrane dekat sini. Dia macam ada blister. The cell tu ada blister. That's why you call it blister cell. What happens actually is the hemoglobin is denatured dan dia macam sediment ke bawah. So dia nampak macam ada blister. Yang ini dia punya margin is very clear kan? Yang ni very clear kan? Yang ni tak clear. So this is blister cell. This is bite cells. And this is fragmented cells or also known as schistocytes. Fragmented cells or schistocytes. So these are the cells that lies in the vessels, intravascular. Okay. Sel-sel yang macam ni nanti dia akan masuk dekat spleen, akan lies dekat dalam spleen. Yang ni dia dah fragmented dalam vessels. So that's why you nampak dia fragmented cells. And you will also see reticulocytes. This is reticulocyte, reticulocytes, reticulocytes. Okay. And when you look at the urine, it will be red or dark coloured. Okay. Ada soalan G6PD? Nanti buat clear lah sebab you dah pernah tengok sebelum ni kan. Now we go to thalassemia and hemoglobinopathy. Dah dengar thalassemia, hemoglobinopathy? Pernah tengok patient? Tak ada. Any family member with thalassemia? Anyone has screened yourself for thalassemia? Dah. Anyone positive? Tak ada. You should screen. You should screen yourself because in our population is about 5% carrier rate. You never know if you are a carrier. I am a carrier. And I screen all my kids. So far 2 are positive. So I will be a very selective mother-in-law lah. Okay. So if you look at the map, we have thalassemia in this belt. This is the thalassemia belt. Southeast Asia, India, Middle East and the Mediterranean countries. Sickle cell anemia is mainly in the African countries as well as the hemoglobin C. Hemoglobin D is mainly in India and hemoglobin E is in Southeast Asia. Okay. So it is a group of hereditary disorder and commonly seen in tropical and subtropical countries. You have a lot of variants but only about 1/3 are clinically significant. So this results from reduced rate of normal alpha or beta globin chain synthesis or synthesis of abnormal hemoglobin. It's either the amount is low or abnormal structure. Okay. So generally thalassemia you classify it to alpha and beta. Alpha and beta thalassemia. And thalassemia is characterized by reduced synthesis of the globin chain. Kalau reduce alpha, it is alpha thalassemia. Reduce beta, it is beta thalassemia. It is an autosomal recessive inheritance. And thalassemia minor or trait, they are usually asymptomatic or mild. So you never know if you are a carrier because you are asymptomatic. Thalassemia major, they have severe chronic hemolysis. Inheritance pattern ni you dah belajar kan, Mendelian style? Okay. Okay, the normal RBC, semua tahu kan? Mainly your hemoglobin is hemoglobin A about 96%, which is alpha 2 and beta 2. 3% HbA2, alpha 2, delta 2, and 1% is hemoglobin F, alpha 2, gamma 2. Okay, so this is the hemoglobin punya structure. So HbA is a tetramer, 2 alpha, 2 beta, and alpha chains are encoded by 2 alpha globin genes in chromosome 16, and beta chains are encoded by a single beta globin gene on chromosome 11. So 11 and 16. For beta thalassemia, kita tengok beta dulu. We have more than 100 mutations. So thalassemia is mainly, beta thalassemia is mainly mutations. Tapi ada banyak sangat variety, more than 100. And mostly result from single base mutation. Maknanya satu amino acid saja yang berubah, and it can cause a severe condition. Severity will depends on the type of mutation. Walaupun kita ada more than 100, tapi bukan semua clinically significant lah. So the clinical nomenclature for thalassemia, we divide it into major, intermediate and minor. Thalassemia major, they are severe, they will require regular blood transfusion. Biasanya every 4 to 6 weeks, dia kena datang for transfusion. Because we want to optimize their growth. Kalau tak, dia akan ada growth retardation. Thalassemia intermediate, they are also severe, but they don't require regular blood transfusion. Dia hanya perlu transfusion bila ada stress to the body lah. For example, ada infection, ada ladies with pregnancy, or ada illness lah. So dia punya HB akan drop, then they will require transfusion. Thalassemia minor or trait, they are asymptomatic or sometimes mild anemia, tapi asymptomatic lah. Dia ada mild anemia tapi tak ada apa-apa clinical presentation. But you can see red cell abnormalities. You akan nampak hypochromic macrocytic red cells. So you can detect carrier from screening. So that's why I advise you to go for screening. So the pathogenesis, you have reduced synthesis of beta globin. And when you have reduced beta globin, you will have relatively excess of alpha chain. Sebab tadi ada 2 alpha 2 beta kan. So bila you kurang beta, alpha you tu akan lebih daripada beta kan. So these will form insoluble aggregates within the red cells. And this will cause membrane damage and reduce plasticity, and they will be destroyed in the spleen. Okay, so patient will have anemia. And other than that, they will also have destruction of red cell precursor in the bone marrow or ineffective erythropoiesis, which leads to anemia. And the inadequate hemoglobin A formation will cause anemia. So this is the main problem with thalassemia. Anemia is the main problem. So the clinical features, the anemia is severe in thalassemia major, but dia bukannya at delivery terus ada. Usually after 6 months old. Biasanya patient akan datang at about 1 year. 1 year age baru datang. And for the moderate one, moderate lah. Dia jarang occasional transfusion, tak perlu transfusion. Growth retardation, if untreated, they will have growth retardation sebab tak cukup oxygen. Oxygen carrying capacity. And intermediate, they can have mild retardation. Hepatosplenomegaly is marked in thal major and moderate in thalassemia intermediate. Why do you think they have this hepatosplenomegaly? Hemolysis. Okay, what else? Ada 2 sebab kenapa dia akan ada hepatosplenomegaly. Satu is hemolysis happens mainly in the spleen. Satu lagi, because of the severe anemia, you have extramedullary hematopoiesis. Okay, so that are the causes of hepatosplenomegaly. Bone expansion, they can have severe bone expansion, extramedullary hematopoiesis. Moderate in thalassemia intermediate. Iron overload, severe in thalassemia major. Why do you think they have iron overload?
Tak ada.
Hemolysis in the spleen, so you recapture the iron, you akan ada iron overload. And the more important one is the regular blood transfusion. You bagi blood transfusion together with the iron kan. So that is the cause of iron overload. So other complications they can have osteoporosis, endocrine disorders and a lot more lah. Okay. So yang trait tu tak ada apa-apa lah. Biasanya tak ada simptom pun. Okay. Why do you think beta thalassemia major, their presentation is not at birth? Dia inherited. But why not at birth? Dah tunjuk dah ni. Yang tunjuk berapa ni? Gamma. Okay. This is at birth. At birth, what is the main hemoglobin?
Alpha.
Alpha and gamma.
Okay, hemoglobin F and also
Gamma.
alpha and gamma kan? And also goer, yeah? And you will have your beta daripada dalam ni dah in utero dah ada dah beta punya production, tapi dia akan jadi maximum here kan? You akan develop the hemoglobin A, alpha 2, beta 2 maximum after 6 months. Okay, barulah you nampak the symptoms tu because beta tak cukup. Sebelum tu hemoglobin F cover still lagi okay kan. So that's why their presentation is usually here after 6 months. Okay. And this is the clinical features of thalassemia major. Nampak pale? Nampak jaundice? Yeah, they have jaundice because they have hemolysis kan. So they are pale, they are jaundice, and this is a typical thalassaemic phases. Boleh you describe? Anyone can describe what is thalassaemic phases? Normal ke tak normal muka dia tu?
Abnormal. Tak normal.
Abnormal. What are the abnormality?
Swollen cheek. Swollen cheek.
Smaller cheek?
Swollen.
Swollen cheek. Okay, what else? Dia tak ada gambar dari tepi dari tepi boleh nampak lebih prominent. But if you look at this picture, the prominent part is here. Nampak dia punya maxilla tu macam protruding because it is expanding because the extramedullary hematopoiesis. And also kalau you tengok daripada tepi, you akan nampak dia punya frontal bone is also bulging. Yeah? That is the typical thalassaemic phases because of the extramedullary hematopoiesis. And if you look at the X-ray, skull X-ray, you akan nampak this phenomenon which is known as hair on end. Nampak dia macam biasa skull kan dia punya border tu cantik je kan, very sharp kan. Yang ini nampak macam ada hair because this skull is actually very active, having hematopoiesis. And when you examine the patient, you have enlarged liver and spleen. In thalassemia major, usually you have massive splenomegaly where it cross the umbilicus. This is umbilicus. Dia cross daripada left to the right. So kalau massive macam ni, biasanya kita akan advise for splenectomy lah. Okay. Okay, clear beta thalassemia. Kita nak pergi alpha pula. Okay. Okay, now we go to alpha thalassemia. So most cases are caused by deletions of alpha globin gene. Beta tadi mutation Alpha is deletion. And the severity is related to the number of genes deleted. The most severe form is when you have 4 genes deletion, you will have hydrocephalus. This is hydrocephalus. This baby died in utero lah, meninggal in the womb. Hydrocephalus just means that the baby is swollen. So you will have a swollen baby. Nampak mata dia semua kan swollen and also enlarged placenta. If you have 3 genes deletion, it will cause hemoglobin H disease. So the clinical spectrum of alpha thalassemia, normally kan kita kata ada 2 allele kan for alpha kan. So each allele will have 2 genes. Alpha ada 4. Normally in normal condition, all are normal lah. In carrier, you will have one gene deletion, and usually they are asymptomatic. But if you look at the red cell, they are hypochromic microcytic. So this one also you boleh detect in the screening. Alpha thalassemia minor, which is also asymptomatic, they lose two genes, two gene deletion, either in different allele or in the same allele. Tak kisahlah, both are asymptomatic and they have microcytic anemia. If they have three gene deletion, it is hemoglobin H disease. They are symptomatic and they have hypochromic microcytic anemia and also splenomegaly. And if you lost all four, it is incompatible with life, in which you have hydroxyuretase. In hydroxyuretase, there is a relative excess of beta or gamma globin, and it will form stable beta 4 or gamma 4 tetramers, which is known as hemoglobin H and hemoglobin buds respectively. So you akan nampak hemoglobin H and hemoglobin buds. Buds is HbH is in 3 gene deletion, buds is in 4 gene deletion. Bila you ada excess beta, dia terbaliklah dengan beta tadi, excess alpha kan, sebab dia tak ada dia punya pair. Okay, investigation. You akan ada hypochromic microcytic anemia and isopoikilocytosis, target cells, reticulocytosis. You will see nucleated red cells or normoblasts in the peripheral blood, and you will see H inclusions, only in alpha thalassemia. Bone marrow, you will see hyperplasia, and your diagnosis, you need to do HB analysis. So this is the blood film. And isopoikilocytosis just means the size and shape of the cells is various. Kalau tengok macam-macam bentuk ada kan cells dia, and the cells are hypochromic microcytic. And if you notice in this film, you have a lot more target cell, kan? Target cell, lagi clear daripada tadi kan? Because in thalassemia, usually the anemia is more severe compared to iron tadi. And if you do supravital stain, you will see H inclusions. These are the H inclusions. Okay, the H inclusions is the excess beta tadi lah. So some books describe this as golf ball cells. Dia nampak macam bola golf kan? Ada dotted. Okay. And if you look at the hemoglobin electrophoresis or HB analysis, dah pernah tengok ke masa biochem? Pernah? Electrophoresis pernah buat? Hemoglobin ke benda lain? Protein saja. So HB analysis, normally you kan ada hemoglobin A, mainly is A, and a small portion of F and A2 kan. So this is the normal one. In beta thalassemia, you akan ada reduce hemoglobin A kan, kalau trait, sebab your beta you kurang kan, so A akan kurang. So the body will compensate by producing more hemoglobin F and hemoglobin A2. Kalau you compare dengan normal, this looks thicker kan. So in trait, dia akan jadi macam ni. Tapi in major, A dia biasanya tak ada langsung or very minimal. So you akan nampak lebih banyak F dan A2. Okay. Alpha thalassemia sama je macam normal. Okay. The hemoglobin analysis sama je macam normal. Yeah. And in hemoglobin H disease, you akan nampak ada satu fast band di ujung sini, which is hemoglobin H. Okay, so the diagnosis, if you suspect a thalassemia carrier, you should do hemoglobin analysis. If it is normal, probably it will be alpha thalassemia. If you see raise A2 and F and reduce A, it is beta. Okay, and to confirm alpha, you have to do DNA study. Tapi sebelum you buat DNA study, you treat lah dengan iron dulu, sebab iron can also have same presentation kan, hypochromic microcytic kan. So you treat with iron dulu. If it normalize, probably it's just iron. If it remains, you have to go for DNA analysis. So the treatment for thalassemia major, they will need regular blood transfusion, but this will give the risk of infection, from the blood. They are risk of infection with HIV, hepatitis and all that, and also risk of iron overload. So if your patient started on blood transfusion, you need to give them iron chelation therapy to remove the iron from the body. Otherwise, patient akan cepat dapat iron overload lah, which is toxic. And you also need to supply them with folic acid, and you can offer splenectomy if they have massive splenomegaly. Usually we will wait until 6 years old, because they are high risk of infection. Endocrine therapy, because when they have iron overload, they will have a lot of endocrine problems. Vaccination for hepatitis B and C because of the risk of infection from the transfusion. And the ultimate treatment is by stem cell transplantation. Okay. It is available in Malaysia. Memang ada buat, dekat HKL pun ada buat, mainly from the family members lah. Stem cell transplant. Complications. Okay, complications is actually a lot. They can have thromboembolism and vascular dysfunction because of the hypercoagulability and platelet dysfunction. Dia sel dia akan banyak walaupun non-functional. Sebab dia HB dia low tapi dia try to produce a lot of cells. And because of the ineffective erythropoiesis, they have anemia and the bone will start to become thin, because bone tu terpaksa work hard kan. So the cortical of the bone will be thin, so they will have bone pain and fracture. And because of the extramedullary erythropoiesis juga, dia akan ada hepatomegaly, splenomegaly and thalassaemic phases. Because of the chronic hemolysis, dia akan ada risk of gallstone, and the iron overload from the hemolysis and also from the transfusion will lead to a lot of other problems. They can have endocrine dysfunction because this iron will deposit to the endocrine glands. Okay, so dia akan ada pituitary problem, pancreas, parathyroid, the gonads, and in the liver they will have cirrhosis. In the heart they can have arrhythmia and heart failure. So most of the thalassemia major patient die because of the heart failure. Okay, clear thalassemia? Okay, sickle cell anemia, dah pernah dengar dulu? Dah belajar masa fisio. So this is also a familiar hemolytic anemia due to single base change in the DNA coding, where you have adenine replaced by thymine. If they are homozygotes, that means both genes are affected, or hemoglobin A is replaced by hemoglobin S. If heterozygous, only one gene is affected, only 50% is replaced. So this deoxygenated hemoglobin S will undergo polymerization and they form long fibers or crystallization. So this will distort the shape and it becomes elongated and concentric. Dia nampak macam sickle. And initially it is reversible. Kalau you bagi oxygen, it can reverse back to normal, but eventually it becomes irreversible. So clinically, they can have severe hemolytic anemia and they can be associated with vaso-occlusive crisis. This is the most frequent, which is precipitated by infection, acidosis, dehydration and hypoxia. Dalam keadaan biasa dia okey-okey je. Cuma bila ada these precipitating factors, they will have this crisis. So this can cause infarction, because it occludes the vessels. So they can have bone pain, dactylitis and stroke. And they can also have visceral sequestration crisis, because they have sickling within the organs. And if it happens in the chest, they can have sickle chest syndrome. They can present with shortness of breath and chest pain, and this is the most common cause of death. They can also have hepatic and splenic sequestration. That means the cells are all sequestered in the liver and spleen, so they have anemia, liver spleen enlarged and abdominal pain. They can also have aplastic crisis, sama juga macam yang tadi, due to parvovirus infection or folate deficiency. And in this condition, they have acute anemia. And they can have hemolytic crisis, and other features are like leg ulcers, splenomegaly in infancy, and pulmonary hypertension. Sickle cell ni jaranglah jumpa. Occasionally ada among our population, but now with the tourism and all that, you may see more patients with sickles. Okay, their anemia is usually quite severe, 6 to 9 grams per deciliter. And when you look at the blood film, you will see target cells, sickle cell, Howell-Jolly bodies. And you should do sickling test to confirm the diagnosis and hemoglobin analysis. Okay, this is the blood film. This is a case of heterozygous, the moderate one. You will see sickle cell here. They are spindle shape or boat shape, some people call it. Yeah, boleh identify tak? Boleh, it's quite clear. And this is a homozygous. You will see a lot more the sickle cells. Okay, ni memang kena boleh diagnose lah. Senang je ni. And if you look here, dia ada juga the target cells. Nampak tak? Ni, they have target cells. If you look at the hemoglobin analysis, you will have reduced hemoglobin A, and they will have another band here, hemoglobin S. So this is the heterozygous, this is the homozygous. Lebih banyak daripada S. Management, you can prevent the disease, the crisis by avoiding dehydration. If you need to give vaccine, you give vaccine. Avoid hypoxia and stasis or pulling of the skin. You give folic acid, you give vaccination. Regular oral penicillin until puberty. And if they are in crisis, put them in rest, warm room, rehydrate, give antibiotics, analgesia, and blood transfusion if required. And the ultimate treatment is stem cell transplant lah. And most of the patient will survive until 50 decade. Prognosis better than thalassemia tadi. Okay, immune hemolytic anemia. It can be auto or allo. So autoimmune are caused by production of antibody against your own red cell, and they are characterized by positive homeostasis. They can be classified into warm and cold type, depending on whether the antibody reacts strongly with red cells at body temperature or at a lower temperature. Okay. Alloimmune is antibody produced reacting with donor red cells. For example, transfusion of ABO incompatibility or hemolytic disease of the newborn. So in warm IHA, the red cell is coated with IgG with or without complement. So these cells will be taken out by the spleen, and it will be prematurely destroyed. And warm IHA can be associated with other diseases. It's quite common to see warm IHA with lymphoma and CLL. Biasa jumpa. Drugs can also cause IHA. And if you withdraw the drug, you stop ubat tu, it will resolve. So clinical features, it can occur at any age. The severity depends. Some can be severe, some is just mild, and they will remit and relapse. Sekejap ada, sekejap tak ada. And they have enlarged spleen because it is extravascular hemolysis. And may be associated with other disease. And the diagnosis is from the blood film, you will see anemia, spherocytes, and reticulocytosis. And you need to do Coombs test. It will be positive. Tak pernah dengar Coombs test? Basically, it's just to detect antibody lah, whether on the red cells or in the serum. So you have direct Coombs test or indirect Coombs test. Direct Coombs test is to demonstrate antibodies on the red cells. So patient's antibody is already coated with antibody, and you bagi antibody, you incubate with other antibody to detect the antibody on the cells. Indirect Coombs test is basically to detect antibody in the patient's serum. Okay. Cold IHA, The antibody attached to red cells mainly in the peripheral circulation at a lower temperature. Kalau warm tadi IgG, cold IHA is usually IgM. And they bind to red cell best at 4 degree. It causes intravascular and extravascular hemolysis. At body temperature, IgM may detach, but complement activation will lead to hemolysis in the extravascular. And at lower temperature, the cell will agglutinate. So this will cause sluggish blood flow because of the agglutination and reduce oxygen saturation as well as chronic hemolysis. For cold IHA, it can be caused by acute atypical pneumonia. Biasa kita nampak dengan mycoplasma pneumonia, and also with infectious mononucleosis. And sometimes the chronic cold IHA, it can be idiopathic. We don't know what is the cause, and can be associated with lymphoma. So the presentation, they have jaundice, enlarged spleen, acrocinosis. Acrocinosis ni dia sakit dekat hujung-hujung jari dia because of the sluggish blood flow tadi. And maybe associated with the disease. And chronic hemolytic cold IHA is aggravated by cold. Bila musim sejuk dia lagi severe. The diagnosis, you look at the blood film and they have positive Coombs test. Okay, this is warm IHA. You akan nampak a lot of spirocytes. Okay, sebab sel ni kan dia ada antibody on the membrane. So bila dia lalu ke spleen tu, it will be the spleen tu akan makan part of the membrane and it becomes spirocytic lah. So you will see a lot of spirocytes and reticulocytes. These are reticulocytes. Whereas in cold IHA, you akan nampak red cell agglutination, very prominent here. And in this case, it is associated with CLL, chronic lymphocytic leukemia. These are the CLL cells. So this is associated with CLL. Okay, ini I just simplify it in the table form untuk mudahkan nampak. Management for warm IHA, biasanya dia associated with infection tadi kan. So you remove the underlying cause. You can give steroids because it is immune reaction. If it is severe and prolonged, you can offer splenectomy. Because the hemolysis is in the spleen. You can also give immunosuppressive agents so that your body won't produce the antibody. And currently you have a specific treatment. You give monoclonal antibody, which is anti-CD20 and anti-CD52, which will attack the lymphocytes so that it won't produce antibody. And you can also offer intravenous immunoglobulin to neutralize the antibody. For cold IHA, keep the patient warm because cold will precipitate the hemolysis. Treat the underlying cause, and you can also try monoclonal antibody. Multi-disease of the newborn, you dah belajar kan? Dah belajar research and ABO, multi-disease of the newborn. Dah belajar kan? Semua pun dah tak larat, nampak? It's quite simple. You baca je nanti you punya nota lama. And this is the pathogenesis. You pun dah tahu.
My
tahu. Okay, nanti baca je, tak faham masa TBR kita discuss. Okay. So clinical features. Kalau severe disease, you can have cardiac fetalis, intrauterine death. Sama juga because hemolysis, the patient is severely anemic, they can have cardiac fetalis. Moderate disease, they can have anemia and jaundice, liver still enlarged, and pnicterus. Pernah dengar pnicterus?
Nah.
Severe jaundice. Go to the brain kan. Okay, so the diagnosis, you look at the full blood picture. Patient have anemia, reticulocytosis, and erythroblastosis fetalis, which actually means you have a lot of nucleated red cells in the peripheral blood. Okay, Coombs test will also be positive because this is immune. Okay, immune reaction. Any immune hemolysis will have positive Coombs cell. Coombs test. And raise serum bilirubin. So the prevention, dah belajar? Prevention of multi-disease of newborn. Okay, you identify the mother's ABO and rhesus group at booking. This is routine, This is routine at booking pregnant mother. If mother is rhesus positive, tak ada masalah. If mother is rhesus negative, then you have to be careful, You screen for NTD. Tengok mother tu ada tak NTD in the serum. Kalau dia ada NTD, maksudnya dia pernah expose to rhesus positive cells. Sebab ABO and rhesus ni dia terbalik kan. Kalau ABO, you group A, you ada B antibody kan. But in rhesus, you tak ada antibody tu. Unless you are exposed. Okay. So you screen for the NTD. Kalau it is positive, maknanya dia dah ada exposure, you just close monitor. If it is negative, you give NTD injection. Okay. And once the baby is delivered, look at the baby's ABO and rhesus identification. If it is positive, you give prophylactic NTD within 72 hours of delivery. Kalau negatif, tak payah apa, monitor saja. So the aim of this prevention is to prevent NTD formation in rhesus negative mothers. Nampak ke dia punya rationale of doing this? Kenapa you bagi NTD injection? You tak nak dia ada NTD kan? Nanti dia ada NTD, dia attack your body kan? Kenapa you bagi NTD injection? You bagi a small dose supaya kalau dia expose with the rhesus positive cell, dia tak terkejut and produce a lot of antibody. Okay? Rhesus fragmentation syndrome ni boleh baca sendiri. Dia tak Okay. It is a physical damage to the cell on abnormal surface. For example, patient with artificial heart valve. Heart valve kita ni biasanya dia lembut. The artificial one ni dia keras tau. So, that will cause physical damage to the cell. And other causes like AV malformation or microintrahepatic hemolytic anemia. Pernah dengar? Hemolytic anemia due to problem with the small vessels in DIC. Pernah belajar DIC? Tak pernah juga. Disseminated intravascular coagulation. Belum kot lecture Dr. Nida nanti kot. Dia ada lecture nanti on DIBC. So in MAHA, basically what happens is it cause damage to red cells because in DIC you have a lot of fibrin strands in the vessels. Because you have disseminated intravascular coagulation. Bila ada coagulation, dia ada fibrin strands kan? So the red cells has to pass through these fibrins and will cause hemolysis. And it is also associated with other clotting abnormalities and thrombocytopenia. So other causes ada banyak sebenarnya with fragmentation syndrome like hypertension, SLE, TTP, cancers. So your investigation is look at the blood picture. You will see schistocytes and reticulocytes. Schistocytes ni the fragmented cells because they pass through the fibrin tu dia pecah kan. So you akan nampak fragmented cells. Okay. This is a picture of MAHA. Nampak tak sel dia ni? These are the fragmented cells ni. Okay. So these are the fragmented cells. Reticulocytes belum ada lagi kot ni, very acute agaknya, tak nampak. And other causes of hemolytic anemia ada banyak lagi. If you are interested, you can read on your own lah. Extra knowledge lah. Okay. I think that's all. Okay,